is pills, lactation amino methods, and then the more effective methods, which is the implant, the IUDs, vasectomy, and biototal irrigation. Those are the best, where the failure rate is less than 1 pregnancy per 100. So like all medicines and the devices, each of these could have side effects and complications. So in the next slide, we see that most of these, next slide, please. Most of these devices and the drugs we use for family planning have some side effects. Some side effects are common and the others are rare. And these side effects may go away over time. Some are easily treated. We say that most of the side effects from family planning committees should last not more than 6 months. Usually they should be going away in 1 to 2 months, but if they are to persist, they should not persist beyond 6 months. You may have to rethink the method if the side effects are persisting beyond that. It can be unclear if side effects are caused by the method. Some of the effects people have been tolerating, So sometimes what we report as side effects may have already been there, but then they become enhanced during the time of using the method or when the patient wants more because of the method they are using. And then clients may experience one or several side effects. It does not mean that if you get excessive bleeding, you don't get other effects. So the effects may be many in one person. And side effects can vary by brand or severity. Severity may also vary by method. So the brand of medicine, if you are using microgynon, you may get some side effects which may be slightly less than another similar combined contraceptive. And being on an injection, you may get side effects which are from those of the other. So they may vary by brand and by type. Next slide, please. So the definition. Next slide, please, Elizabeth. As far as the definition is concerned, that side effects are minor problems which are short-lived, and they usually subside within a short duration of time, 2 to 3 months. They should have gone. Whereas, next slide, whereas complications are more serious. Next slide, please. Elizabeth. Yes, okay. Whereas complications are problems which require urgent medical attention. So if you get a problem which requires urgent medical attention, that is no longer a side effect. It has become a complication. Elizabeth, can you move the slides, please?
I am moving the slides. I only think I have internet issues.
Okay. It has gotten stuck at side effects. Okay, good. Now, what are the influences of side effects? The initial decision to use the side effects may influence the initial decision to use a family planning method. After you have counseled the patients and you tell them about side effects, the initiation of the method may not, clients may fear to initiate a method because of fear of side effects. And the side effects may make a continuation of methods. Discontinuation of methods. We find that in Uganda, if 100 women started the method, 50% will drop off within 1 year because of side effects. So we see that they have a big influence. It can satisfaction with the method. People may be satisfied. They get unacceptable. The method may become unacceptable to them because of the side effects they're experiencing. So this is how important it is. It can impact on the decision to use the continuation and with the particular method. Yes, these impacts can be reduced by discussing the side effects before the method is. If a patient selects a method when they know what they will face, and they say they tolerate that, then they are to tolerate the effects and continue with the method. So discussing the side effects with the client before initiation is very important, that they know what it is and what they will face and how that will be managed. And managing the side effects promptly and practically is very key for continuation of the methods, and also allowing method switching. If in case the method is causing unacceptable side effects, we should allow us to switch to other methods. But despite this, many providers do not inform clients about side effects. The next slide. And why would this be the case? These providers know the side effects, they have the clients, but they don't inform them about these effects. Yet they know that informing clients about side effects will make them most likely tolerate the side effects, make the family planning methods more acceptable to the client. We fear to tell them these clients. The main reason is that maybe we are too busy. The clients are too many, and you think that if you start going into digital counseling about side effects, benefits, and whatever, you don't have that time. Some people worry that if clients know that clients may reject the methods after knowing the side effects. And some people are unaware of the consequences of actually the side effects. The health workers may not be aware of the frequency, how often does the side effect occur. So they will not indulge in that discussion. And the lack of support materials, the teaching aids and the job aids may be lacking, and therefore the service provider may be uncomfortable discussing side effects. But we should have, so the solution is that reassure that counseling can be brief. Not every patient takes a lot of time. Some people have already come with made up minds and they want an explanation on how to use their method and what they will face. So I think sometimes the counseling can be brief. We need to provide our healthcare workers with the literature, the right information, such that they articulate the right thing, not coming with assumptions and reassure that side effect counseling increases the use and the continuation of family planning methods. And to give providers training, we need to give training to our providers on how to manage common side effects, and then provide simple reading materials for providers in case they face patients with side effects. Yes, next slide, please. Yes, side effects. Which are the common side effects? We have the common side effects. What we have here are mainly side effects from hormonal methods. Hormonal methods have similar side effects, whether they are combined or contraceptives, combined injections, the patch, or whether they are injection, whether they are progestin only. The only difference is the severity of the side effect will depend whether the method is, whether the contraceptive is combined or progestin only. But otherwise, they have similar side effects. So headache can be a side effect. But if this headache is very severe, then that is no longer a side effect, it is a complication. You need to refer that patient urgently for medical attention. Increased menstruation is a side effect, but should the menstruation be so heavy with the clots and the patient is become collapsing and needs blood transfusion, that is no longer now a side effect, it has become a complication. The menstruation may be like no menstruation, that is a side effect. Menstrual cramps may be a simple side effect, but if the cramping is very severe, or there's constant abdominal pain, chest pain, leg pains, these are serious complications which we must refer the clients or we must reassess the clients and make sure that what is causing this, because severe chest pain in a patient using a COC or an implant, an indication that she's having is an indication that the patient may get ischemic heart disease, heart attack. And if you have leg pains, it's an indication that you are likely to be developing clots in your calf muscles. And if you have pains in the belly, then we may think that you are actually having cysts that may be undergoing torsion and causing severe constant pain. So we need to reevaluate this client and decide on which care to give. Some other side effects are weight gain or loss, which is usually due to increased appetite or loss of appetite. Because when you eat, if the contraceptive makes you eat too much food, you are going to gain too much weight. Or if it makes you get nausea and the loss of appetite, then you're going to lose weight. Vaginal dryness and the local skin irritation, these are simple side effects which can be dealt with. However, if you see the skin or eyes of the patient are becoming yellow, it means there is liver damage. And we need to reassess that patient and see if we should continue with the method or change. Loss of sensation in the arms or legs, those neurological effects are not side effects, but main complications. There are some consequences which we must tell our patients. And these negative or positive consequences, we need to tell them and they get aware that if they see or they feel these consequences, they need to come back to us, or they should not be surprised. For example, you may feel weak, unwell, feel weak, too weak to work, unable to participate in religious activities. Religious communities will not really, many women who have frequent bleeding, continuous bleeding, may not participate too much in religious community activities because bleeding, like if you're Muslim, you are not going to go to the mosque when you're bleeding. Some men will not allow you to prepare food for them if you are in your periods, and that can be frustrating. Some of the methods may make you feel unattractive if you develop pimples and you become too big. And then that's what you call body image in the current. How does body image affect contraceptive use? Being fat or too thin, and then limited sexual activity because of loss of libido and the dryness. These will be negative consequences. But on the other hand, some people get some positive consequences, like enhanced sexual pleasure. Like if you have IUD, the springs are causing the cervical glands to produce a lot of vaginal mucus. Cervical mucus, which lubricates the vagina. Then some people may get enhanced sexual pleasure, and some feel more attractive. Yeah. Some people may look attractive and the others. And so if you have these negative consequences, you may sometimes have to discontinue contraceptive method or use it irregularly. It may cause people to discontinue the method or may use it irregularly. Okay? So, now, what do we do to treat these side effects? Treatment, the next slide. Elizabeth, the next slide. In treatment, Elizabeth, you have gone away?
Doctor, we are the use of soap.
Hey, you have reached the soap. So now management of FP-related side effects and complications, you can use the soap process in managing side effects. So is an acronym which collects subjective data and you make your own assessment.
Excuse me, doctor.
Yes,
Dr.
please.
Kakaire, I think you switch off your video so your network will be better.
After all, you are seeing darkness. Okay, thank you. Is it better now?
It will improve, I think.
Okay. So the acronym is the process of contraceptive side effects. And here we collect the data with the patient. A patient may tell you that I'm bleeding a basin of blood every day, which is not possible. A human being has only about 6 liters of blood, 5 to 6 liters. A person has about 20 liters. If you lose 20 liters of blood, you cannot be walking. So subjective data we got this information. Then we objectively examine the patient. And after examining the patient, we put the subjective and objective data and we make our own assessment. After this assessment, you make a management plan. So next. So next slide, please. That one is, we have done that assessment. Now,
example.
Then example, we go to the example. If we do subjective assessment, we ask how long she has been bleeding. Ask if bleeding from the period of amenorrhea. Ask if bleeding is more than her use of it. And ask if they have a bleeding or she had it for the blood. And then ask whether the bleeding follows sexual intercourse. These are some of the questions which you may ask, because if she is bleeding after sexual intercourse, the implant of cervical cancer from developing, and this person having another pathology in the pelvis that is caused bleeding. If the bleeding started before the implant, then we cannot attribute the bleeding to the implant, but it is the pathology in the pelvis that is causing this. So this is subjective is good for us to correct and understand. Next, we now do we collect objective data. We do the signs, we collect for signs, we look for signs of anemia. If somebody is really bleeding heavily, she should be pale, mucous membranes, the conjunctiva is pale. Look at the penile bed, the palms, and the tongue. So let us examine the patient fully and see if there is evidence of dizziness. Check a pad, see if she's bleeding now. We need to look at the pads and perform a pelvic examination. Use the speculum to look at the cervix, look at the vaginal walls, and do a bimanual examination to rule out cancer of the cervix, abortion, subsidies, and anemia. These are to now be what we have as our assessment. We look out for, and then we combine the subjective information with the objective information. Then we do the assessment. Based on the subjective and objective findings, conclude if bleeding has become a health threat or not. Exclude other underlying medical or gynecological problems and anemia. And make a concrete conclusion of diagnosis. So this is something we need to do, and we have to have made a conclusion. We make a plan. So how do we make a plan? Very heavy, prolonged bleeding, more than 8 days or twice as much as how many period. We give these patients normally in the family planning, we start with ibuprofen. We start with ibuprofen. Is the drug which we give to people who are having bleeding disorders due to family planning methods. And the doses are quite high, 800 micrograms, 400 micrograms to 800 micrograms, 8 hourly for 5 days. We need to take into consideration that many people nowadays in towns are under a lot of stress, and they have gastric or peptic ulcers. So we need to be sure that we give these drugs to people who don't have ulcers, and they should take them with the meals, after meals. When you have eaten, you can swallow. Otherwise, you can use other methods like mefenamic acid, tranexamic acid. Mefenamic acid is also an anti-inflammatory drug, but it has less gastric effects than ibuprofen. Unfortunately, most of the health facilities don't buy mefenamic acid. We give it 500 milligrams 8 hourly for 5 to 7 days. If not, you can use tranexamic acid, which has no effect on the gut, and it causes platelets to coagulate and form a clot and stop the bleeding. It's more efficient than all this, but it is a bit expensive and not available in health facilities. You have to go and buy from the pharmacy. If bleeding stopped after those tablets, you reassure her. If the bleeding has now stopped before you examine her, you may have to reassure her that she can continue using the method. If the bleeding persists, we can give low dose combined oral contraceptives in those people who are using progestins, the implants, the injection Depo-Provera, Cyanopress. If bleeding persists after using the non-steroidal anti-inflammatory drugs, we may have to give you a COC, 1 cycle, sometimes 2 cycles, and then we discontinue and the bleeding will stop. If bleeding persists after using the COCs and the client is very uncomfortable, counsel have another method of her choice. So here we can decide to switch. If the bleeding persists, you give the ibuprofen interferons, mefenamic acid interferons, tranexamic acid interferons. COCs have also failed. In somebody who is using progestins only, then you may have to switch to another method, which is non-hormonal. Evaluate and treat an underlying medical or gynecological condition, or refer if you cannot manage the gynecological condition. So these people can have endometrial polyps, they can have uterine myomas, they may be having hematological disorders like low platelet counts, bleeding disorders, coagulation disorders. So these people, if you do hematological indices and you find the medical condition problems, then it is better we refer them to the appropriate doctors, whether the physician to look at the hematologist or a gynecologist to deal with a physical problem which is in the genital tract. Yes, so these are the drugs which we are talking about, non-steroidal anti-inflammatory drugs, ibuprofen, and you may use mefenamic acid if you have it, and these are progesterone inhibitors which construct the uterus, or tranexamic acid, which is a thrombin drug which causes thrombosis. It makes microthrombi forming in blood vessels which have opened up and bleeding, and then they put a plug and stop the bleeding from occurring. Tranexamic acid, if good enough, it can be given as an injection. It can also be given as a tablet. If somebody is bleeding heavily and comes to you and you have tranexamic acid, 1 gram IV, 1 gram given IV will stop the bleeding in the next 30 to 45 minutes. And then she can continue and go home on tablets for another 5 days. So if you don't have the injection, then you may have to give only the tablets if you have them. Now, hormonal contraceptives, the other effects which is common with the hormonal contraceptives is amenorrhea, missed periods, which may concern a client. Well, you know, ladies want to have their periods. Something which takes away the period brings concern to these ladies. They don't know whether they are pregnant, the fear of pregnancy, or they think this blood is collecting somewhere and is going to become a swelling. So these people need to be reassured. You investigate and cover that what is the missed period. Do they know what a missed period is? Is there any spotting? Sometimes when you are using hormonal contraceptives, you don't expect to get the real period. You may just get some spotting in your panties or some staining of the underwear, and that is it. So because the endometrium thins out, it becomes so thin, and the amount of blood loss decreases so much. That's why most of these hormonal contraceptives are used to protect people from anemia. Yeah. So we have to be sure that they didn't get some spotting of some sort or staining, and ask how she has been taking her pills. If some people take pills continuously. If you have a 21-day, a packet with 21 active tablets and no iron, people may move from one packet to another without break. And if you don't break for 7 days, you will end up having amenorrhea. So we need to ask the patient how she has been taking her pills, and then rule out pregnancy. Is she pregnant? She could have actually conceived. If you are taking pills irregularly, this time you take in the morning, the next time you are taking at bedtime, the other time you are taking at lunch, that kind of irregularity can actually cause you to ovulate and conceive and get pregnant. So we also always say, if you are on a pill, take it at the same time every day. If you choose bedtime, take it at bedtime. If you are choosing early morning when you are waking up, so it doesn't matter whether it is a combined oral contraceptive pill or it is a mini pill, all pills, you have to take them, you have to choose a time and take them at that time consistently. If yes, the amenorrhea is concerning, concerning the patient, is of concern to the patient, to the client, low dose pills users can expect very scanty or no bleeding at all. If you are using a low dose pill, you may expect very scanty, and most of the pills we have now are low dose. The microgynon is 30 micrograms of estrogen and the 15 micrograms of progesterone. So the amount of drug, the hormones are low. So there is a possibility that somebody may get very scanty bleeding. Missed pills or pills taken late raises the risk of pregnancy. Clients on a 21-day pills pack may forget to leave a pill-free week for menses and they just continue with the pack. If the client is pregnant, refer her according to the pregnancy. If she intends to continue with the pregnancy, she should stop the COC and continue with her pregnancy. If you conceive when you are taking COCs, you are taking POPs, you are on injection, whatever method you are using, there is no family plan method which will cause the abnormalities in the baby. You just have to discontinue the method and continue with the pregnancy. Next. Has she recently discontinued the pill? Now, when you discontinue the pill, you remember that the pill suppresses the hypothalamus and the pituitary, and you don't release what? They don't use FSH and the LH. Now, if you discontinue the menstrual bleeding, which you get every month, is just withdrawal bleeding. The effect of the hormone on the endometrium is what you are seeing. Now, when you withdraw the pill, the time it takes for the brain to wake up and start producing FSH and the LH vary from person to person. There are people who will not get amenorrhea after discontinuing the pill, but there are people who will get amenorrhea for 6 months before they see the periods again. So if the client is not pregnant, explain that there may be a delay in return of her menses after stopping the pills. If her periods were regular before beginning the COCs, they will be irregular when the COCs are stopped and may take some months to return. Help the client to make an informed choice for another contraceptive method if she chooses that she wants to continue with family planning, but she's not interested in having no periods, because the periods are treasured in our society. The other thing which can be a big problem more than amenorrhea is spotting or bleeding between periods, also called breakthrough bleeding, commonly during the first 4 months after starting pills. These pills, actually, it is not just pills, but also starting hormonal contraceptives, even the injection, even the implant, you may get these breakthrough bleedings, but it is common with the pill, the combined pill and the pill plan. Ask if the client has recently begun the contraceptive. Ask if she has missed one or more pills, and if she takes pills at regular time every day. Ask if she has had much vomiting or diarrhea. Now, if you take a pill and you get diarrhea or vomit before 30 minutes elapse, it means that pill had not been absorbed, and you will have to take another pill, because this one you have lost it in the vomiters or in the stool. So if you take and vomit, that means that the pill is not working. It is not there, it has been thrown out. So you reassure, acknowledge that this is annoying but not dangerous, and expect it to resolve within 2 to 3 months. If necessary, instruct the client. If the client has had vomiting or diarrhea, explain that this may have interfered with her body's absorption of the COC, and recommend condoms or abstinence for 7 consecutive days after the vomiting and diarrhea resolve. So those are some of the things which we can do. Now, the next slide, ask if the client has any new medications that they may be taking. Remember that Some drugs interact with the COCs, with the hormonal contraceptives. Some drugs interact with our hormonal contraceptives, especially the anticonvulsant, anti-TB drugs, and some antiretroviral drugs, which are efavirenz or nevirapine-based. So if you have those, they may have actually reduced the effect of the contraceptive, and therefore the client may require to change the method of IFU on such drugs. Yeah, implants have been shown to lose their potency by a year if you are on antiretroviral drugs. So we tend to advise, but now they are the new drugs which are coming on the market are not interfering much with the implants, but that was a big concern before. You put the implant and 1.5 years later, she's pregnant. So we are now using new antiretroviral drugs which have helped us to reduce the incidence of pregnancy among HIV positive persons using implants. So spotting and bleeding, you need to exclude gynecological problems such as pregnancy, abortion, cervical infection, PID, or tumors. Ask if the client has ever had a normal pap smear within the last year. This is very important that family planning providers should not only provide family planning, but it should be a screening area for other diseases, including hypertension, cancer cervix, cancer breast. So we need to use this as a wellness clinic to check on other problems which may happen, because if you don't, and somebody gets a breast mass and it reaches the extent of becoming cancerous and you have not detected it, we shall always blame the family planning that we used for that. Ask if spotting follows sexual intercourse. Has she changed sexual patterns of recent? Those are things which could cause problems. Rule out pregnancy, cervical infection, PID, and gynecological cancers by pelvic exam. If available, do cervical cancer screening. If more than a year has passed since last one was done. If a gynecological problem are present, refer or manage according to policy and guidelines. Yes. Now, if none of the above, you find that, next slide, if you find that spotting and bleeding continues, but you are not detecting anything, there's no gynecological problem, there are no hematological issues, what is it that you can do? If no gynecological, drug interaction, or other problems are detected, breakthrough bleeding may be due to inadequate support of the uterine lining. You may then switch to a more potent progestin. If the progestin in the combined pill or the progestin you are using, like a tenogestol, or whatever is less potent, then we may have to go to levonorgestrel. Or we may have to put her on a high-dose estrogen pill, 50 micrograms instead of 30 micrograms. So if she's on progestin only, contraceptive, we put on an estrogen-containing pill to try and build up the endometrial lining. We know that the endometrial lining, when it is exposed to progestin only, it thins out and becomes as thin as paper. And the blood vessels below it can actually rupture and continuously keep bleeding. So you give some estrogen-based product, which may encourage the endometrium to grow back and prevent these blood vessels from just rupturing, from desiccation, from dryness. So you can do that. You can happen, and then that person, after a cycle or two, she can continue with her normal contraceptive. If it was a implant, if it is a Depo-Provera, we can now leave her alone and she continues. Another alternative is try her on prostaglandin inhibitors, like the NSAIDs, as we have already said, the ibuprofen, the mefenamic acid, and the tranexamic acid. Yes, next. Next, please. Nausea is another problem which is common, and it may seem like you have a pregnancy, and this is very uncomfortable for too many people, losing appetite and failing to eat. So find out if the COC that are taken in the morning or on an empty stomach. When you take a combined pills on an empty stomach, you will get nausea and you may actually vomit. So you need to put some food in the stomach before you take the pills. rule out other causes of nausea. Is it infection, malaria? And if none of those, then if the client is pregnant, discontinue the sources and refer her. If she's not, advise the client to take the pills with the evening meals. Evaluate for infection like hepatitis, gastroenteritis, HIV, and other causes of nausea. Or you can switch to a progesterone-only method and reassure that nausea may be limited to the first few cycles or the first days of each cycle. But it has also been noted that when you are on pills, when you are on hormonal methods, pills, implants, and whatever, there is a tendency to have a nutritional deficiencies. Nutrition deficiencies where you lack vitamin B2, B6, B12, minerals like selenium, manganese, and zinc. Now, these lack of these vitamins and some of those micronutrients can actually cause nausea, and you may end up with vomiting. So this is something which people can go and do some research here locally and see how many of our women on hormonal contraceptives actually end up with the vitamin B2, B6, B12, manganese, zinc, and the selenium deficiencies. And in some countries, actually, it is a routine replacement of those micronutrients in the people who are on hormonal contraceptives. Here, it is not yet the policy. Then the other thing we need to look at is headache. Headache, we have listed it as a side effect, but it can also be a life-threatening condition, which we call a complication. So you should listen carefully to a serious client who is complaining of headache. Severe headaches, usually those that involve vision, changes of speech, or problems may be an early warning of a stroke. General questions on headache should include whether they occur when the client has menses, whether she can function with her headache daily, and what medications reduce the headache. So if you think this headache is threatening to become a stroke, refer the patient urgently if you suspect it may be a stroke. If it is not, you need to rule out sinusitis and nasal issues. Are there pain in the sinuses? So if they are, then you refer them to the ENT surgeon for treatment, and they may continue with the COCs. Ask whether she has ever had high blood pressure. If you have ever had high blood pressure on combined or on hormonal contraceptives, you are at high risk of having an elevated blood pressure. And therefore, the blood pressure should be assessed, and we check the blood pressure. If it is elevated, then we should ask our colleagues to manage the high blood pressure for us. If you are able to manage it, please go ahead and give the antihypertensive drugs. And depending on the severity, if the hypertension is very severe, then the hormonal contraceptive must be discontinued, and you start her on another hormonal contraceptive. So try to distinguish between muscular contraction tension headaches and migraine headaches. The presence of neurological symptoms may suggest a severe migraine headache. This client is at risk of stroke. Strongly advise her not to smoke tobacco, and if she has had neurological symptoms, stop the COC. Progesterone-only methods or other non-hormonal methods may be used. Rather, you may refer as necessary to be treated by a physician. Generally, migraine headaches can vary from mild, severe pain is often located in the temporal areas and throbbing in nature. Nausea or vomiting may be present. Clients may have a warning aura that headache is about to occur. Some clients experience neurological symptoms, vision changes, flashes, and double vision, numbness, tingling sensation, weakness in the limbs, speech or memory problems. If the client describes headaches without neurological symptoms, she may continue COCs. You have to keep a record of the frequency of the headaches and return to the clinic after 2 to 3 cycles, or sooner if the headache worsens. So headache is another big problem. Next is ask if the headache was since she began the hormonal contraceptive. If the headache was on COC, switch to a low dose COC. If we progestin only or non-hormonal contraceptive method may be better for. If the headache is worse with COCs, you may switch to progestin only or non-hormonal methods. What is this?
Yes, Doctor.
Yes, please. The next is the high blood pressure. High blood pressure is something which may appear with the usage of hormonal contraceptives, or it may be something which comes in with the client when she already has high blood pressure, but she didn't know about it. You know that for us, we are in a race that is prone to cardiovascular complications, including high blood pressure. And this disease starts appearing at the age of 35 in us blacks. So if you are 35 years, you should start checking for high blood pressure. And now when you now add the hormonal contraceptives, which increases fluid retention, they cause water to be retained in the body. That now makes the blood volume go up and increase the chance of raising your blood pressure. Therefore, we should be checking our clients for high blood pressure as they come back for refill. We should not just give them the contraceptives. Oh, go where you are doing very well. Thank you very much. Go. You need to keep checking their level. Ask if the client is the first time anyone has told them they have high blood pressure. Ask if she has ever had symptoms suggestive of high blood pressure, such as headache and dizziness. Recheck BP on 2 more visits 1 week apart. This is something which I cannot recommend. If the blood pressure is 180/100, you can leave the client to rest in the clinic for 30 minutes or 1 hour. If you repeat the measurement and the blood pressure is still the same after that rest, then this patient should be treated or referred to some person who can treat the high blood pressure successfully. In your settings, you will be done to treat. You give your nifedipine, you give your meldopine, and losartan, whatever. For us here, we have those people who are specialized to treat those. I will not touch, I will just refer. So here you have to treat the patient if the blood pressure is this high, this is severe hypertension. So you may allow a 15 to 30 minutes rest, making sure the BP curve fits the patient correctly, repeat the blood pressure reading. If the systolic reading is greater than 180 or higher, and the diastolic reading is 110 or higher, the client smokes or is over the age of 40, please stop the COC. Otherwise, switch to a low dose COC or progestin only contraceptives, or you can actually tell her to switch to a non-hormonal method and turn in 1 week. Remember that even if you switched to implant, you switched to the Provera, these are still going to cause the water retention and increase the risk of the blood pressure going up. Yes, next. Weight loss or gain. Weight loss, weight gain, as I've already said, is that if you are using hormonal contraceptives with progestin only, it is worse than the combined contraceptive. The combined contraceptive, you gain some weight because it also has the progestin in it. But the progestin only contraceptives have the tendency the progestin acts like androgens. Androgens are male hormones, which gives people appetite for food. So you have a high appetite. Patients should be warned that if you see your appetite increasing, you may need to control the way you approach food. Otherwise, if you just eat, you will have a serious weight gain. It is estimated that in 1 year you will get about a pound, 3 to 4 pounds of 3 to 4 kilograms when you are on implant or Depo-Provera or Cyana. So you have to be very careful what you eat. Otherwise, weight can be a problem. And this is now the issue what you are saying, body image. The body image, people look at themselves in the mirrors and see they are putting on, the dresses are no longer fitting or they're becoming too tight and they feel uncomfortable. So weight loss or weight gain, weight loss is the other side, is the estrogen effect of nausea, or vomiting, loss of appetite, which is more common with the COCs. If the client is pregnant, weight gain, could it be pregnant? Refer her accordingly. Inquire about eating habits which might promote weight gain, weight loss. Ask about a change in work, sleep, symptoms of depression. Yeah. If the client denies poor eating habits but complains of increased appetite or weight gain without apparent cause, ask if the weight gain is unacceptable. So if the client is pregnant, refer her to the antenatal clinic. Instruct the client to proper nutrition and exercise. Yeah. Counsel her and refer if depression is detected. Again, depression in hormonal contraceptives is a deficiency of vitamin B6 and B2, B6, and B12. You end up with depression. So that is where issues can be. Explain to the client that all hormonal contraceptives may have a slight effect on weight, but those in COC is very low and should have only a little effect. Counsel her for other non-hormonal methods like IUD or BTL or vasectomy if the husband can allow. Then breast tenderness is the next problem which this forget. Breast tenderness is determine whether the woman is pregnant by history and pelvic examination, determine whether the woman has breast lumps or nipple discharge, suspicious of cancer. If she's breastfeeding and breast tender, examine for breast infection and ask the client to know if she has, whether the client notices this only when she's using the hormonal contraceptive. So these hormonal contraceptives tend to, as I said, to make the client gain fluids. And these fluids are going to go into those loose tissues. The loose tissues are mainly the breast and the feet. The shoes no longer fit very well because they are swollen. The water accumulates there. So if the client is pregnant, of course, we shall refer her, discontinue the COC. If physical examination show a lump, discharge suspicious of cancer, stop the COC, help her make an informed choice of another method, and then refer her for appropriate evaluation and management. If the breasts are not infected, recommend proper clothing support. If the breast infection is present, use warm compresses and advise to continue breastfeeding as we give appropriate antibiotics. And then we may counsel clients to consider switching to another method. So this is about the breasts. They can be a problem. Some people give actual diuretics to these ladies to remove the excess fluids. Aprinox is a very commonly used to remove the excess fluid which these ladies could be having. Now this is another issue, loss of libido, sexual drive. Ask if this is due to other causes such as dry genitals, painful intercourse, or marital issues and family problems. If no other cause is found, ask if the client sees this as a serious problem. Then you may have to cancel or refer as appropriate. If yes, switch to a more androgenic progestin such as the levonorgestrel or etonogestrel. Now, what causes the loss of libido is that the hormonal contraceptives increase the sex binding protein in the serum. And now this sex hormone binding protein, when they increase, they bind the androgens in saturation. And even ladies, to have sex drive, they must have some level of the male hormones. Now, if the male hormones are depleted, this person is going to have a loss of libido. and that is going to be a problem. So there's advice that this also, and this loss of this increase in sex binding globulin is seen in patients who have lost vitamin B6, B12, and B2. So you may have to consider also supplementing their diet with the multivitamins. So encouraging them to eat a lot of vegetables and fruits and drinking a lot of water would be of help. Asthma is a condition where people get patches in the face and over the body. Some parts are dark, others are clear, and they think you see it most commonly in pregnant women. So the mask of pregnancy, usually on the upper lips, under the eyes, the forehead. So they get patches, and people may not be happy with this. It is common with cirrhosis. Ask about other causes, for example, skin lightening creams containing mercury, recent pregnancy, and sunburn. Look for tinea vesicola or other skin diseases, and if no cause is found and the problem is not improving, we need to cancel on stopping creams and avoiding the sun. If recently pregnant, advise to wait for 3 months and look for improvement because asthma disappears naturally. Treat or refer as appropriate if no other cause are found, and if some facial darkening is associated with cirrhosis or other hormones, including given the implant, also you get this, is perceived by the client to be intolerable, help the client to choose another hormonal method, such as the IUD or a permanent method. So that is depression now is also a common problem. Ask about cause, for example, for family, financial, and social problems. Ask if she's eating and sleeping regularly. If no other cause is found, ask the client if she thinks depression has worsened while on the hormonal contraceptives. Mainly the estrogen component is the biggest cause of depression. Answer accordingly and follow up during next visit. If the client feels the depression has worsened on the COC or is due to the method, consider changing to a low dose COC. Some clients might choose to wait and see instead. Sometimes periods can cause decrease in pyridoxine, vitamin B6, which subsequently lead to depression. You can prescribe pyridoxine 20 milligrams daily. If she's not happy, let her choose another hormonal method. So you see that these micronutrient deficiencies which occur in contraceptive users, hormonal contraceptive users, mainly the B2, B6, B12, selenium, manganese, and zinc. And you know that the oxidative pathway is zinc and the selenium, which plays a lot of role in detoxifying the body and whatever. That's why you see that these people may end up with it. Accumulation of the toxic lipids, the low density lipoproteins, hypertension, and whatever. So we need to be very careful as we prescribe these effects. So next is just a brief look at the IUDs. The IUDs have been seen to be one of the best contraceptive methods. They may be hormonal or non-hormonal. The hormonal IUD has a lot of advantages. It is working locally in the uterus. It releases the hormone in the uterus, stops the bleeding. So people with heavy menstrual bleeding should be encouraged to use the hormonal IUD. The bleeding will go away. They will have no periods or spotting, mild spotting, and they will have a very good life. It also takes away cramping. So the cramps go away and somebody feels okay. And we use it to treat endometrial hyperplasia or endometrial hyperplasia as therefore preventing endometrial cancer. But the copper IUD, which is the most common IUD in Uganda, is not, although it protects us from uterine cancer, it can cause cramping and backache in the first few months after insertion. Usually we say that this should last not more than 6 months. If it lasts more than 6 months, then you may have to rethink to change the method. And this clamping can be mild, or it may be very severe. And when it is very severe, you may think, because most of the STIs in Uganda are diagnosed syndromically. It is said that 50 to 80% of women with the STIs in Uganda are not asymptomatic. 50 to 80%. If they have gonorrhea, they will not be having symptoms. If they have chlamydia, they won't be having symptoms. Therefore, it is possible that you go and insert an IUD in a person where you will see with your naked eye that the cervix is healthy, there is no infection. You insert the IUD in there, and you actually transfer infection from the cervical canal into the uterine cavity, and then this person will get infection. So this infection related to IUD will occur in the first 21 days after insertion. If you get a patient coming back to you with an infection when she's wearing an IUD more than 21 days, more than a month, that person has acquired the STI during the use of the IUD. That is not related to the IUD. And that one is a problem of sexual life. We remember that most of these hormonal contraceptives, most of the contraceptives we have discussed here do not protect anybody from STIs. Therefore, we must be ready to always tell them these methods are very efficient at stopping pregnancy, but they are not good at stopping STIs. If you have a risk of STIs, please, you must use a condom or dual protection. Now, irregular periods may occur. So IUDs are associated with the menstrual changes, which is irregular periods, painful periods, spotting, heavy periods, and those are the main effects. Then there is vaginal discharge. Some of these guys, as I said, if you are using the hormone IUD, there is a problem of dryness. The cervical mucus does not get, the cervix does not produce mucus because of the powerful androgens in the IUD, and therefore the patient will complain of vaginal dryness. But in the copper IUD, there is increased fluid production, which makes people wet. Therefore, in that situation, if you are giving somebody a copper IUD, she's going to come back with a vaginal discharge. It is not a disease, but it is just excessive cervical mucus secretion, which you should always advise them to use a cotton panty. They should use cotton panties or a panty liner to take away the moisture. Otherwise, if you have fluids and you have a nylon panty, they are going to encourage fungal growth, the growth of a fungus. You will be scratching all the time, and you said the IUD has caused me an infection, when actually it has just caused an increase in your genital fluids, and those fluids are the ones causing this. Now, for irregular periods, spotting and bleeding, again, the treatment here is the non-steroidal anti-inflammatory drugs, the ibuprofen, the mefenamic acid, and if those don't work, then you go to tranexamic acid. Now, if the cramping is persistent and continue, then you may think maybe there was some infection. You may need to give a full dose using the syndromic approach, the full dose for STI. That is Fixim 400 milligrams start, and the azithromycin 1 gram daily for 3 days. Now, if you have expulsion is common in IUD use, about 6% of people who have had an IUD inserted have expelled it. It is a side effect which happens common, which means that you are no longer protected. That's the danger it has. Once the IUD is expelled, then it is no longer protecting you from unwanted pregnancy. So the expulsion could be complete when the IUD is thrown out of the uterus completely, or it may be partial when a part of the stem peeps through the cervix, and usually the husband may complain that he's feeling something piercing him. Don't laugh out at the patient, just examine it and you'll see the stem looking at you, and pick it out, take out that IUD and reinsert another one, that partial expulsion. Now, sometimes the IUDs may lose their strings. These strings may be that they came off because of the acidity of the genital fluids, the IUDs may lose their strings. Or it may be that the strings have coiled themselves into the cervix, or it may be that the IUD has somersaulted, such that the T is now at the internal os and the stem is at the fundus. So this can happen with the IUDs. What is important if the strings are lost is to do a scan and find out if the IUD is in its rightful position. If it is in its rightful position, do nothing about it until the lady or the client will want to have it removed. Then you can actually remove it using the crocodile forceps if the strings have been lost. So that is what we do. Infection, if the patient comes with an infection with while using an IUD and you diagnose PID, the immediate action is not to remove the IUD. First, treat the patient. After giving antibiotics for 48 hours, evaluate and see if she is improving. If she has improved, the symptoms have gone away, the discharge has stopped, you treat the husband, leave the IUD to continue. If the patient is worried and she feels that the IUD should be removed, you can go ahead and remove. But otherwise, if she's responding well on antibiotics, do nothing. If she's not responding well, the infection is becoming worse. After 24 hours of antibiotic use, take out the IUD. The most serious complication is uterine perforation. When you insert an IUD in the uterus, there's a chance that you may perforate the uterus at the time of IUD insertion. Once the IUD has been released in the uterine cavity, it has no ability of perforating the uterus. All perforations occur at the time of IUD insertion. And therefore, the provider should be careful enough to detect whether she's feeling like she has perforated the uterus. If you have any doubts about perforation, if you think you may have perforated the uterus, either through the reaction of the woman, you see she's feeling too much pain, or you feel that you are not feeling the fundus. If you are not feeling the fundus, don't release the IUD. Just come out with the IUD, leave the patient alone, let her rest, monitor her BP. If she's settled, cancel her on something else and let her go home. You will give her some other method, then she may come back after some time and you will insert the IUD. This uterine perforation is commonest in women who have just delivered in the postpartum period, those who are 6 weeks postpartum, or those who are breastfeeding. Those are the people who are likely to perforate. Perforation is not common. It occurs in 1 to 2 per 1,000. 1 to 2 patients should be perforated in 1,000 if you are an experienced provider. Some providers have never perforated anybody, but please be on the lookout, because if you perforate and you release the springs, the IUD will migrate into the abdominal cavity and you will need to do a laparotomy to retrieve that IUD. So it becomes very expensive on the side of the client and the service provider going into operate this patient, look for the IUD after X-ray, you have located where it is, then you go and remove it. So ladies and gentlemen, that is briefly what I had for you today. And I think I should do break at this moment and hear from you. One other thing which I would want to tell you is that, so we are looking at contraceptive-related side effects and some complications, and we shall walk through slowly. And also, because I know that on the fora, there are health workers and there are also non-medical people who may want to get information from us. So I've made it a little bit easy and quite easy to understand. The next slide. So family planning methods are many. Some are chemicals, others are devices.
Sorry, Dr. Elizabeth, can you do a full slideshow? And thank you.
I'm working on it.
Okay, Doctor, you can go ahead.
So I hope we can do that. So the methods, as you can see in that slide, the effectiveness is in a step-ladder fashion. You move from the less effective methods like the spermicides and washing over the genitals after sex to condoms, mon beads, and finally you go to the next tier, which is injection